Good afternoon. My name is Jeff Kwong. I'm the Interim Director of the Center for Vaccine Preventable Diseases at the Dalhousie School of Public Health. I'm very pleased to welcome you to our webinar today on COVID-19 immunogenicity, effectiveness, and safety surveillance. So this panel discussion will provide an overview and updates on these topics in Canada. It will build upon our previous webinars on COVID-19 vaccine safety surveillance in Canada and COVID-19 vaccine effectiveness, both held earlier this year. Before we start today's webinar, I'd like to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people across Turtle Island, and we are very grateful to have this opportunity to work on this land. So just a few housekeeping issues. We will try to address as many questions as possible. So direct any questions you like answered by the panelists to the Q&A function that you'll see at the bottom of your screen. You can direct any questions you have after this webinar to the email address cvpd.dlsph@utoronto.ca, and that is going to be put in the chat, so you'll see the email address. We also have closed captioning in English available during the webinar. Instructions on how to view closed captions will be listed in the chat. So please keep in mind that this is an automated service, and we apologize for any errors made in the captions. So now I'm going to just introduce our panelists. So I'm Jeff Kwong. I'm a professor in the Department of Family and Community Medicine and Dalhousie School of Public Health at the U of T. I'm also a senior scientist and the program leader of the Populations and Public Health program at ICES, and also a scientist at Public Health Ontario. I also work as a family physician at Toronto Western Family Health Team, and I'm one of the researchers with the Canadian Immunization Research Network, a provincial collaborative network. Next, I'd like to introduce Dr. Philip Awadallah. Dr. Awadallah is the Director of Computational Biology and Senior Investigator at the Ontario Institute for Cancer Research. He's also a professor of population and medical genomics at the University of Toronto and the Executive Scientific Director of the Ontario Health Study, or OHS. He is also the Director of the Genome Canada Canadian Data Integration Centre and the National Scientific Director of the Canadian Partnership for Tomorrow's Health, or CanPath. And third, we have Dr. Natalia Abraham, who is a public health and preventive medicine physician and epidemiologist, who is currently working at the Public Health Agency of Canada as medical advisor and manager in the Vaccine Safety Division. She is actively engaged with the NACI Secretariat and provides support on key files, including COVID-19 vaccination in pregnant and breastfeeding individuals. So we'll start. We'll have three presentations, one on immunogenicity by Dr. Awadallah, followed by one on effectiveness by myself, and then lastly, one on safety by Dr. Abraham. So we'll start with Dr. Awadallah, and do you have your slides available?
Hi there, just getting my slides up.
Right.
And I presume we can see everything. We're good. Okay, thank you very much, Jeff, for that introduction. So very happy and pleased to be presenting and reporting on some previous results and also some new results from our program funded generously by the Partnership of the PHAC organization, Population Health in Canada, as well as CRHR. And first of all, what I wanted to describe today is some of the work that we're doing with a population cohort, the Canadian Partnership for Tomorrow's Health, the CanPath cohort, and the Support Canada activity, which is being supported by PHAC and CRHR. So as was mentioned during the introduction, can we get through the slides? Here we go. Yeah. I'm the National Scientific Director for CanPath, which is Canada's largest population health study. It's a national platform for longitudinal health research. We have recruited over 330,000 Canadians, largely as a cohort to study the development of common and rare chronic diseases, as well as cancer. And this is going to be a really short presentation today, so I won't be getting into a lot of the details in terms of the characteristics of this cohort. But the infrastructure behind this cohort has enabled us to develop the work that we've been doing to support COVID-19 research. And one of the things I also want to mention and make sure it comes across is that the data we've been collecting, not just for CanPath, but all of these other factors that we've captured with regard to the long-term health is available to the greater research community, as is the COVID-19 related data that we've been capturing as well. So as I mentioned, it's Canada's largest population health research platform. We are now 7 cohorts from all 10 provinces. We're actively recruiting in 2 provinces still, in Saskatchewan and Manitoba. Actually, when I say still, they're new cousins to the activity. So we're still pulling in baseline data from those regions. But we already have, as I mentioned, 330,000 participants registered in the cohort, and we've captured everything that you can see here on these slides, where people come in, they filled out questionnaire data, they provided biologics, physical measures on about 100,000 participants. We're actively engaged in things like longitudinal follow-up with these participants. And for the great majority, almost all 330,000 participants have agreed to allow us to link to administrative health records. They give us information about their health insurance numbers, and personal information allows us or enables us to do that. These are the names of the partnering cohorts that make up CanPath, and I'll be able to acknowledge the leadership of these great leaders leading in each of these individual activities, supporting the CanPath activity. As was mentioned during the introduction, I lead also the Ontario Health Study activity hosted here out of the Ontario Institute for Cancer Research. And here in OIC at OHS, we've recruited over 200,000 participants. So I really want to focus today, the time that I have, on the activity called Support Canada, which is our COVID-19 activity. I certainly want to acknowledge Kim Skeed, who's the National Scientific Coordinator, and helped develop a lot of the Support Canada initiative. And also I want to highlight Victoria Kirsch, who's a member of the Ontario Health Study research team, who's largely responsible for most of the analyses that you're going to be seeing here today. And so the Support Canada activity began effectively in March and April of last year, with the collection of COVID-19 related data from our participants, initially with the start of a COVID-19 survey and questionnaire, and then we moved into looking at serological surveillance with the support of PHAC, the Public Health Agency of Canada, and CIHR. So we started collecting COVID-19 related data from over 100,000 Canadians who've given us, if you like, survey information, serological information. Now on 27,000 participants, you're going to see some data on that primarily today. And this data actually is now turned into looking, instead of antibodies and immunity associated with the virus, largely associated now with vaccine and immune profiling with regard to post-vaccine status. So the kinds of things we were captured in the COVID-19 questionnaire at baseline was information about COVID-19 test results, any symptoms experienced, patient participant hospitalization, et cetera, potential sources of exposure, and so on. So I don't have time today to get into this, all of the results that we've captured today. I'm going to give you snippets of this. I presented this at various meetings before, or webinars before, but some of the information that we're capturing, look at things like racial inequities with regard to COVID-19 in Canada. We're seeing, for example, that ethnic minorities are 2.1 times more likely to be infected with COVID-19. Again, this is information captured largely from the first, if you like, 2 phases or waves of the pandemic, when this information was being captured. We don't think that's really changed that much. And other things that we've been capturing are information about occupation, and were there specific occupations that were more likely at risk with regard to COVID-19 infection. And I was actually slightly surprised to see this, but airline people who work at the airports or people who work in the airline industry are more likely have the highest risk in our data compared to other occupations as well, and certainly significantly more so. We're flying around through the slides. I really wanted to focus the remaining time that I have here talking about some of the serological work that we have here. We've been collecting blood spots of those 100,000 participants who filled out those surveys. We actually invited around 27,000 participants, or just over 27,000 participants, hoping to get 20,000 participants. And in fact, what we're seeing is 27,000 participants. So we had to adjust our budgets to enable that high participation rate. So it really does say something about how engaged the population is in trying to help us understand the science, if you like, around COVID-19. So 27,000 participants have given us blood spots, and some of the data that you're going to be seeing here today is largely going to be focused on the information we've captured with regard to antibodies. Sorry, my slides are acting up on me today. Here we go. And some of this work is done, and I want to highlight our colleagues at Sinai who've been collecting the serological data for us from the blood spots. And Claude Gingra's team is the team that have developed a 3 antibody test for us to be able to capture information about proportions of antibodies. And what you're seeing here on the y-axis is a relative scale to some reference to the population reference. We're seeing response, if you like, with regard or seroconversion rates for, in this case, nucleocapsid proteins as they relate to, which is an antibody that's going to be more specific to viral infections. And what you're seeing here, of course, is those individuals that did report that they were COVID test positive have the highest proportion of nucleocapsid proteins with respect to, so these are just individuals who tested positive for COVID-19. And then when we look at antibodies that are more specific, if you like, to spike proteins and or receptor binding domain proteins, we're seeing how they relate to the different vaccinations. Pfizer here in purple, AstraZeneca and Moderna, and you're seeing, of course, elevated rates associated with vaccination. This led us to looking at some things that we reported on earlier, that people who were singly dosed with AstraZeneca had actually a substantially lower amount of antibodies than those who were vaccinated with Pfizer or Moderna. Of course, when people were doubly dosed, we saw that those numbers were actually relatively similar. We also started looking at things like influence of age on antibody proportions here. And this is across, this is for both spike and receptor binding domain proteins here. And you can see in these data that for both spike and receptor binding domain, this is for mostly Pfizer, that as people age, the number of proportion of antibodies that we see in individuals goes down. I wanted to really quickly cover a few results that we have looking at antibody response after COVID-19 vaccination among cancer patients and survivors. This is a paper that we're trying to develop right now. So this is very much hot off the press. And we've been looking at, within the CanPath study cohort, at the time of us developing the study, we only had access to about over 16,000 participants. About 9% of those 16,000 participants are either currently in some sort of cancer treatment, sorry, not 9%. 9% were fully vaccinated, had double doses of vaccination here, but a substantial number of individuals in this group were subject to cancer treatments or have been seen a cancer diagnosis since March 2020. So that allowed us to look at the impact of cancer diagnosis and treatment on vaccine response with regard to antibodies. And so what you're looking at here, again, are spike protein proportions, as well as receptor binding proportions for those who are singly dosed, double dose, single dose, and double dose for those 2 antibody types respectively, with regard to either cancer currently being treated, recently diagnosed with cancer, or recent chemotherapy, compared to no cancer at all. And you can see that antibodies go down, particularly for cancer currently treated or those individuals that were recently subject to chemotherapy. That's not a time-dependent analysis, of course. Before we get into that, those are significant. Those results are significantly reduced, so we have some numbers to back those up. And what Vicky's been also doing is looking at how different cancer types are impact, if you like, seroconversion. And what we're seeing here is you can really see this quite dramatically, even for those who are doubly vaccinated, either for spike or for receptor binding domains. Individuals who are being diagnosed with hematological malignancies and or melanomas, which are down over here, we're seeing the most dramatic effects with regard to reduced seroconversion rates or reduced proportion of antibodies. So suggestive that cancer treatment is highly impactful with regard to vaccine efficacy. So again, these are we can make this data available. We will be making this data available in the publication, of course, but you can see here, these are just the p-values and some of the regression coefficients. And finally, this is a multivariable analysis looking at using time in the model, if you like, and this allows us to assess how impactful when was the vaccination relative to the cancer treatment, and were people are we seeing these reductions because the vaccination rates were some time ago versus cancer treatments? And yes, there is an impact of time, but you're still seeing, of course, that we see a significant p-value interaction with regard to history of cancer. So that's all I'll have time to present today. I just wanted to acknowledge, of course, the leadership at CanPath, who've all been critical in helping us collect this data. All the data is available through Campath Portal. So this is the Campath Portal website. And of course, I want to acknowledge the great team we have at the Dalla Lana, where the National Coordinating Center for CanPath is presently. So thanks very much to you for listening. And of course, thanks to the CanPath participants for being so generous with their time and their information.
Great, thank you so much, Philip. So we'll have a question and answer session, and while I'm speaking, maybe you can take a look in the chat and the Q&A, so some of the questions that have come up, and feel free to address them if you'd like via the Q&A or the chat function. In the meantime, I'm going to pull up my slides, and here we go. Let's see now. Okay, so you guys seeing my slides okay? All right. So I'm going to be talking about vaccine effectiveness. What do you know right now? And just no financial conflicts of interest. So just a quick overview of the pandemic, just a review. Our wave 1, which we thought was terrible, looks pretty small compared to subsequent waves. And then we had like wave 2 back in, at the end of 2020 into the beginning of 2021. And then this was an alpha-driven wave 3. And then this is the Delta-driven wave 4. And this was when the vaccination program was brought in, December 14th, 2020. Okay. The next slide just shows the vaccination rollout. You can see here the coverage for a single dose is the dashed line going up here, and then the solid line is coverage for the second dose, so fully vaccinated individuals. And so you can see that, we started in mid-December. At the end of January, there were some vaccine supply issues. And so we had to delay the second dose to 5 to 6 weeks for most individuals. And then in early March, NACI sent guidance saying that we should delay the second dose to up to 16 weeks so that we could provide more protection, at least partial protection, to double the number of people. So you can see that the dose 1 coverage goes up gradually, in the early spring, and then dose 2 coverage doesn't go up till kind of, in the summer when we started getting more supply. And as we did get more supply, then the interval between doses, between dose 1 and dose 2 got shorter again to what was recommended by the manufacturers, like 3 or 4 weeks. Okay. And then just kind of superimposing these 2 graphs I just showed, you can see how, as our coverage went up. It may have been one contributor to wave 3 going down in addition to the public health measures. I think it's probably definitely helped with wave 4 not taking off as far as, taking off as badly as we were fearing, partly because of vaccine coverage and, good vaccine effectiveness. Okay. So now I'm going to talk about the estimates that we've done at ICS. We've used the test negative design, which is a method that we've used to estimate influenza vaccine effectiveness. And so what we do in that, I'll just quickly review this here, is that we take patients who present with, for influenza vaccine effectiveness, people present with symptoms compatible with influenza, so influenza-like illness. We swab them, and then those who test positive, we treat as cases, and those who test negative, we treat as controls. And then we estimate this odds ratio. So the odds of vaccination amongst those who test positive over the odds of vaccination amongst who test negative. And so we do this for COVID vaccine effectiveness now, where we take people who have symptoms compatible with COVID, and who got swabbed. And then we do this kind of like a nested case control study, and we can estimate the vaccine effectiveness. And so previously, Gaston Dessert and colleagues have shown that, that the estimates using the test negative design are comparable to those from randomized controlled trials. So he reanalyzed data from a number of RCTs and then got estimates of vaccine effectiveness that are very similar to the vaccine efficacy estimates from clinical trials. So this is our data up till September 20th. We're actively trying to update this to include more recent data. We did analyses against any SARS-CoV-2 lineage, as well as against just the Delta variant. Today, just because of time constraints, I'm only going to present the data against any lineage, but the results for the Delta variant are basically identical. So just to give you a sense of the number of people who were tested where we had symptoms, they were symptomatic and tested, and how many symptomatic infections we had, how many people who had severe outcomes, which is hospitalization or death, and then how many people had at least one dose as of the date that they were tested. And here, this on the right, we can just see a distribution of the vaccines that people had received by the time of the testing. So most people had received the Pfizer vaccine, and a smaller percentage had received the Moderna vaccine, and then fewer had received the AstraZeneca, and then some who had received mixed mRNA, so either Pfizer, then Moderna, or Moderna, then Pfizer, and then AstraZeneca, followed by an mRNA vaccine of 3%. Okay, so I know this is a bit of a busy slide. I'll just walk you through it. So on the x-axis, we have our vaccine effectiveness. So to the right is 100%. So you want to have the estimates as far to the right as possible. And on the y-axis, it's time since receiving the most recent dose as of the date that you were tested. And so the gray bars represent people who had only received one dose when they got tested for COVID. And the black bars are people who had received 2 doses. And you can see these are increments of, varying increments of weeks after the first dose and after the second dose here. So we combined the 2 mRNA vaccines, so Pfizer and Moderna together on this left-hand side. You can see that there's pretty good VE after 2 weeks after the first dose. And it's, peaks at about 70% and then goes down a bit into the 60s, all the way up to even 16 plus weeks after the first dose. Then after getting the second dose, you can see that the VE is quite high. By 1 week after, it's 94%, and it stays in the 90s until about 4 weeks, then it drops to about 80 something. And then it stays up to 81, even at 32 plus weeks after the first dose. And I forgot to mention that this is against symptomatic infection. This is the outcome, and this is for everyone age 16 or older among residents, among non-long-term care residents. In the middle, we have the AstraZeneca estimates. We combine the Covishield and AstraZeneca together because they're the same vaccine. And once again, you can see pretty good VE estimates comparable to the mRNA vaccine at least 4 weeks after the first dose. And then after the second dose as well, in the high 80s, maybe dropping off a bit here. This estimate's very unstable, so I'm not sure I'll put much weight in here. And then for those who received at least 1 dose of mRNA as well as an AstraZeneca, you can see that these estimates are very similar to those who received 2 doses of mRNA vaccines. So I think that's good news for people who got that combination. They've got good protection as well, as much as the mRNA only recipients. So the next slide is looking at severe outcomes. So this is hospitalization or death. And you can see that we've got actually higher VE estimates against these severe outcomes compared to symptomatic infection. We can see that after the first dose and as well after the second dose. And there doesn't look like there's any indication of waning, even at 32 plus weeks out after the second dose. And then similarly here for AstraZeneca, also very high VE estimates, and the mixed all in the 90s. And unfortunately, we don't have more data to inform these longer intervals. Okay, now when we stratify by age group, you can see that older people take a little bit longer to get the high VE estimates compared to the younger age group. So 16 to 69, you're getting into the high 60s, low 70s by 2 weeks. But here it's only 36%, and then it's at 4 to 7 weeks, you can see it's at 64%. And at the other end, we were only able to look at the 24 plus weeks, the 32 plus weeks. There just weren't enough events to generate VE estimates for the older age group. But you can see there's a suggestion of some waning here against symptomatic infection. But this confidence interval is pretty wide. So I think in the next time we run this, we'll have a better sense of like truly if this is actually lower than this 90% here. And then looking at severe outcomes, though, there doesn't look like there's a whole lot of waning, between the age groups. They're fair, like they're in the 90s still, maybe a bit lower here for the 70 plus compared to the 16 to 69, but still very good. And now, how do our estimates compare to the RCT data? So here I've just flipped it, where I put the vaccine effectiveness on the y-axis, and on the x-axis is time. And so these are just the ones I showed in the first slide, where you can see that the Ontario TND for like mRNA estimates up to the 32 plus weeks. And then you can see for the 2 clinical trials that were done, for the Pfizer in blue and the Moderna in yellow, they had estimates up to 4 months, like 4 to 6 months. And you can see that our estimates are actually very similar to the Pfizer, maybe a little bit lower than the Moderna. But keep in mind that most of the people in Ontario and in this TND study were Pfizer recipients and rather than Moderna recipients. Now, looking at this question of a dose interval, the dosing interval. So the time between the first dose and the second dose, does that impact VE? So what we did is we stratified our population by the dosing interval. So this red line now is just people who had received their doses in less than 5 weeks apart. Then we add a yellow line of people who had received their doses 5 to 7 weeks apart, and then a blue line where we have 8 to 11 weeks apart, and then 12 or more weeks apart is this green line here, which is pretty much superimposed on this blue line. So there is a little bit of suggestion against symptomatic infection that there is a little bit more waning by about 4 months for those who have a short dosing interval compared to those with longer dosing intervals. And we'll just have to wait to see if this blue line continues out this way or if they eventually drop. But between the red line and yellow line, there's a very small difference here. And even this difference between the red line and the blue line is about 10%. So it's not a massive decline. And looking at severe outcomes, there's basically no difference at all between these 4 groups. So just in summary, I think we see very high VE for the mRNA vaccines, even 32 or more weeks after dose 2, with only slight waning against symptomatic infection for older adults, but no evidence of waning against severe outcomes. And our results are largely consistent with RCT data. And lastly, that there are the short intervals between dose 1 and dose 2 appears to be associated with a slight waning against symptomatic infection, but not severe outcomes. So that's all I'm going to be presenting today. Just wanted to acknowledge the people on the team. We're also working with colleagues in other provinces where we're trying to do similar analyses and trying to pool our results so that we can be more confident. And then just have a quick data acknowledgements and disclaimer slide, and happy to answer questions during the question and answer period. Okay, so that's it for me. And then I'm going to hand it over to Natalia next. And okay, thanks, Liz.
Thanks, Jeff. And thank you all for the invitation to speak today. I'm going to provide a brief but informal overview of what post-market surveillance entails at the national level in Canada. I'm not going to go over specific findings, but I will speak high level about the signals that we are investigating. So I work in post-market surveillance, but it's only really one of 3 major ways that we can monitor vaccine safety. So next slide, please. The first is pre-market clinical trials. So before a product is approved and enters the Canadian market, it must meet fairly stringent safety standards set by Health Canada based on their clinical trial data. And it normally accrues over a much longer period of time than what we've seen during the pandemic with the vaccines that have been approved. So it's usually actually observed over several months to years. So we then have large passive and active surveillance systems where reports of adverse events following immunization, what I'm going to refer to as AFEs, are collected. So I'm going to dive more into that in the next slide. So that culminates in national level surveillance data, which actually gets submitted to the market authorization holder, so the vaccine manufacturer, and to the WHO's Uppsala Monitoring Center, which influences statements by the Global Advisory Committee on Vaccine Safety. The clinical trials also continue on after approval for market use has been granted. So independent of all of these surveillance activities, there's a variety of research that can occur. So independent researchers can publish case reports. Researchers can conduct large database studies. For example, a discrete health unit could publish on their health administration data, for example. So throughout all of this, standard case definitions are applied when available, and this allows for direct comparisons and pooling of data. And so an APHE is defined as any untoward medical occurrence that follows immunization, but does not necessarily have a causal relationship with the administration of the vaccine. So the adverse event may be a sign or a symptom, or it could be a defined illness. So we have the Brighton collaboration, which is a group that was put together through the WHO, and they've developed very extensively researched case definitions that are used globally. They also have a number of products that they've developed to aid in the use of these case definitions for countries such as ourselves, high-income countries and low and middle-income countries. So the ultimate question that all of these systems feed into is does the vaccine cause this event in some people, or like can it? And for a given case, did the vaccine cause that particular event? So the science of causality is quite complex, and I'm sure many of you know, establishing a causal link between an exposure and an outcome is a very difficult epidemiological task. I'm not going to delve too much into that during today's overview. So for us, we have 3 levels of causality when we deal with APHEs. The first is causality at the population level, which looks at the large body of evidence. Then we have causation at the individual level, and then there's also signal evaluation. So these all feed into each other, and we conduct all 3 at the national level. Next slide, please. So here's a snapshot of the surveillance cycle in general. So we do collect the data, then we integrate it, we analyze it, interpret it, and then we create products to disseminate, and we evaluate on an ongoing basis. But public health action comes off the dissemination piece of the cycle. And during a pandemic, that's a very key. So I guess the main thing with this diagram, I think probably many people have seen this type of diagram. For us in causality, for us who work in vaccine safety, there's one piece that's really missing here, and that's the causality assessment. And you could really fit that in a number of different places, potentially like right at the end before the collection of data. Next slide, please. Okay, so just to get into, the realm that I specifically work in. So we have 2 passive surveillance systems at the federal levels, and we have 1 active surveillance system. So our passive surveillance systems include the Canadian Adverse Events Following Immunization Surveillance System, which we call CAFIS for short, and it's housed at the Public Health Agency of Canada. Then we have the Canada Vigilance Database, which we refer to as CVD for short, and it's housed at the Marketed Health Products Directorate at Health Canada. So our active surveillance system called IMPACT screens pediatric hospital admissions for various APHEs, mostly neurologic events, and it covers 90% of all tertiary pediatric tertiary care beds in the country. They've now expanded their mandate and are tracking MIS-C and myocarditis and pericarditis as well. So when somebody experiences an APHE, their healthcare provider fills out an APHE form and submits it to their local public health unit. And then after an assessment, which can involve requesting the healthcare records, the record is sent to the provincial or territorial or federal immunization authority. And there, again, it's assessed before being submitted to CAFIS. In some jurisdictions it's mandatory reporting, whereas in others it's voluntary. But overall, the data quality for CAPAS reports is fairly high when you look at when you compare it to other countries, because it's been assessed by multiple healthcare providers along the way. And we also have the capacity to enrich our data by going back to the public health jurisdictions in Canada for more information. So in parallel, Health Canada's Canada Vigilance Database captures cases that may or may not have been reported by a healthcare provider. So any member of the public can make a report, and the media is also monitored for reports. That database also contains reports that the manufacturer submits. So there's like a big risk for duplicates. So Health Canada and PHAC, we work together so that we can identify possible and then confirm the duplicate cases. Next slide, please. So as an example of a surveillance product that we disseminate, our group produces a weekly online report of all APHIs that we've received at the national level. There are a number of types of data we report out on. I've just put a few on this slide, but in general, we take our overall numbers. We stratify by vaccine type, age, sex, and APHI. We include information on safety signals in Canada, but also ACEs, which are adverse events of special interest that have been identified by the Brighton collaboration. I don't have a slide for this, but we identify signals using a number of methods. We use our own data and calculate the number of expected cases that would occur in a given time at risk period based on the number of people in a given age and sex strata that have been vaccinated. So this can come from the literature, or we can actually calculate it directly from CAI data if it is an APHI that a type of APHI that we would have expect a person would have sought healthcare from a hospital for. So we come up with these observed and an expected number of cases, and then we can calculate confidence intervals around these to see if there are statistically significant differences. So right now we have 3 safety signals that have been identified in Canada following COVID-19 vaccination. So the first signal was thrombosis with thrombocytopenia syndrome following vaccination with AstraZeneca and Covishield vaccine. We do have a number of outputs, so that arrow that goes to action. We provide our results to public health jurisdictions across Canada, to NACI and to Health Canada. So for example, Health Canada has updated the product monograph to include information about the thrombosis with thrombocytopenia events. And you know, NACI modified their recommendations when we flagged those events to them early. Our reports are also factored into Chief Medical Officer of Health decision-making across Canada when it came to vaccine programming. So we did identify 2 other signals. There was GBS, so Guillain-Barré syndrome, and myocarditis and pericarditis. So I think, you know, the one of most interest right now, and I unfortunately don't have a slide for you today on this, but I can speak to it, is the myocarditis and pericarditis. So we did find a signal in those only under 40 years of age, and we found it first in males, but it also moved to females once data accrued, and it was most often in the second dose. We're close to finalizing our analyses, looking at the impact of dose interval on risk, and also mixed schedules. Right now on our website, if you look at our numbers, it looks as though Moderna has a higher rate of myocarditis and pericarditis after vaccination than Pfizer. But it's not clear how confounded that is by dose interval, and also mixed doses. So many people who received Pfizer, received a mixed dose schedule in Canada, received Pfizer first and Moderna second. So these can really impact the way that we can interpret our initial results. So, I mean, I didn't get into too many details, but that's the basic overview of how vaccine safety surveillance is conducted in Canada, and what we've been finding during the COVID-19 vaccination campaign. So thanks for your time, and I'm going to hand it back to Dr. Kwong.
Great. Thank you so much, Natalia. Okay, so now we'll have a Q&A session. We've got a large number of questions from our audience, which is great. So maybe the first question, we'll go to Philip. So the first question, let's just see here. All right, so I guess the first question comes from Anne Birchall. When did people provide blood for serologic testing relative to their last vaccine dose? Are there relations between time since last dose and antibody levels?
So thanks very much, Anne, for that question. And that reminded me that I left out a very important part of our study in the description of our activities, and that is we're still in the field and we're actually collecting follow-up blood spots or blood samples from our participants. The great majority of our blood samples were collected and ended in July. They started in March and ended in July. So for many of our participants, again, the great majority of them will have only had a single dose of the vaccine at that point. But because we have pretty large numbers, we still had a large number of individuals who had had a double dose of the vaccine by the time they gave us a sample. So our first wave of collection ended in July, with the exception of Manitoba, where we're still in the field right now, actually getting our first wave. We just started sending out invitations to our participants who provided that first sample to get a second sample now. So that gives us also a longitudinal snapshot, if you like, of how long lasting some of these the antibodies will be. And that activity will continue probably until July of next year as well.
Great, thank you. And now there's a question about, was there a relationship from Kate Allen? Was there a relationship that you were able to look at, a gradient between cancer treatment recency and antibody response? So like 1, 2, 5, 10 years post-treatment?
Yeah, so one of the analyses that Vicky had done for us was looked at, cancer, ever diagnosed with cancer versus a cancer within the last couple of years versus currently undergoing cancer. So that's how we currently have broken the data down. And we were seeing the greatest effect, if you like, with respect to particularly with the cancers where we captured an effect, which was blood malignancies and melanoma. People specifically undergoing treatment right now, we're seeing the greatest impact with regard to reduced numbers of seroconversions.
Okay, and will you be using the data to study long COVID?
So that was a slide I just removed just before we came online today. So we do have some long COVID participants who are saying that they haven't recovered fully. So we don't have, they're not a lot, but they are there in the cohort. And of course, it is generally a rare phenomenon. But we do have data to support that research. And we will be following those participants as well. We'll be asking questions in our follow-up surveys to continue to monitor those individuals.
Okay, thanks. I'll give you a bit of a break, Philip, to catch your breath. Yeah, Natalia, are there any statistics on mortality post-vaccination?
Yes, there is. There certainly is. So we do report those out publicly. I mean, the issue with those are that for many of them, there are obvious other causes for death. So there's a WHO AFI causality assessment manual where you go through systematically assessing causality for a given case. So we do that. We do like a preliminary assessment on every death case. And we try, I think what we're going to be putting out at some point publicly is a report on our deaths that breaks it down by is a given case consistent with a causal association with immunization? Is it unclassifiable, or is it inconsistent? Like the vast majority are inconsistent. The only ones that might actually move to consistent with a causal association are ones where there's been a safety signal identified. Like for example, the deaths that were secondary to thrombosis with thrombocytopenia syndrome after vaccination. So once we can formally actually say that the vaccine causes that event, then we would be able to formally designate those cases as being death cases after vaccination. But it should be on our website. I actually was trying to go through my papers quickly and look through the website to be able to point you to it exactly, but it's in there and it's publicly reported.
Great, thank you. And one more question for you. based on the observations of myocarditis after the first 2 shots, what are the expected outcomes after a third?
So that kind of ties into the question about boosters and safety with boosters. So we have very limited information. One of the things that happened when myocarditis first was being detected is people who experienced myocarditis were recommended not to receive further vaccination as a precautionary measure. And so we have very little data on what happens if you receive an additional dose, if you're one of those. But like in terms of generally, if you haven't had any myocarditis and you want to get a booster shot, we only have 2 studies, one from the US, one from Israel, that gives us a snapshot and of the safety profile of a booster shot. And right now they just look within normal like expectations of local and systemic adverse reactions. So they have just a very normal profile, but they didn't actually detect substantial like myocarditis and pericarditis because the numbers in those samples were too low to detect such an adverse event. So rare event, I mean. So we're waiting to see as the data rolls in, because we can't really predict. We don't know enough about risk factors or anything that might be contributing to the development of these cases other than prior COVID-19 infection. So
yeah, okay, yeah. So we're just kind of just wait and see for that. Okay, just a quick question for me about whether we'll be looking at why did we focus our study on symptomatic infection? And that's based on the way the test negative design works is that it's supposed to be people who are symptomatic who then come in for testing. And the idea of that is that it kind of removes some of the bias from healthcare seeking behaviors. And so, a lot of the studies out in the literature are people, they're looking at any infection. And we know that the vaccines don't provide what we call sterilizing immunity, which means that it doesn't necessarily prevent infection, but it's designed more to prevent the serious outcomes. And so it's not entirely unexpected to see that there's lower vaccine effectiveness against any infection, like asymptomatic infection compared to symptomatic infection, and then even higher VE against the severe outcomes. And so the only issue is that with asymptomatic infection, you may get more bias because the people who are let's say healthcare workers and long-term care staff who are getting tested very frequently for screening, you're going to pick up their asymptomatic infections, and then they're also very highly vaccinated. So then it's going to look like, then it'll make your VE estimates be lower because you'll see people who are infected and also vaccinated, and then that may drive your estimates lower. So the estimates that you see for the asymptomatic infection, part of they're lower. Part of the fact that the reason why they're lower is the kind of truth, and part of it might be some bias as well. And so that's just something to be aware of. I think the thing is that you don't expect that the change over time should be different for the different groups. So that's why we're also going to look at the asymptomatic outcomes as well, or any infection as the outcome as well. And that's just our next thing that we're going to be doing. Okay, so back to the other questions for others. I think this is a question for Philip. If you can comment on the ethnic breakdown of the participants who gave rise to the data that you've shared.
Hi, yeah, so great question. Generally, CanPath follows the ethnic distribution of Canada, where we are very much in alignment with Statistics Canada values or numbers for the ethnic breakdown. With that said, we did try to increase our representativity, particularly in regions that we knew and or groups, communities that we're seeing increased infection rates. And so with that said, the ethnic breakdown is still pretty white, but not as white as the rest of the CanPath cohort, which is 75%. But our breakdown is closer to around 60% white, and for this study, within a breakdown amongst a myriad of ethnic groups in that 40% group.
Yeah. Okay, and one question from Barb Law. Do your data provide any insight into whether or not exposure to COVID variants in communities with high rates of transmission, so especially Delta, provides a boost immunity in the absence of symptomatic infection?
That's a great question. We haven't looked at that yet. That's not, but that is not something that we have really started, but I was just thinking about this, about how we could get at that kind of question with the data we have. So Vicky and I have been spending an awful lot of time trying to develop with ICES an ability to capture information about infection rates as it relates to also what kind of sequence variant has been sequenced and is available for a particular region. So that kind of information would come from our ability to link and our consent to link with administrative records, OLIS, and so on. So I think that might be how we can get at that question. That's a really interesting question. But I think it's doable. It would just take a bit of work with our partners like ICES. Yeah,
we should talk after this, Philip. Yeah, and this other question actually that was raised, it was actually directed at you, but I think might be something that we can answer with ICS data, is looking at vaccine effectiveness amongst cancer patients. And seeing your data made me think that we can use administrative databases to identify people who've had hematologic malignancies, and we can look at vaccine effectiveness specifically in that population to see how well the 2 doses. I mean, now they're all getting the 3rd dose. But we'll see at least, how poor it was maybe after the 2nd dose only.
I agree, Jeff. Sorry, Jeff. Yeah, I just think it relates also to looking at other types of immune. Somebody was asking, is it all, it's not all about antibodies, of course, but we're not collecting blood for, like T-cell mediated responses, but we can presumably see something through linkage administrative data, in terms of whether vaccine still remains effective in those individuals.
Yeah, great. One more question for Natalia here. What is your best estimate of the incidence of myocarditis/pericarditis?
So is this after vaccination or for a background rate?
I think they might be asking it. This is from Joan Robinson. I'm guessing that she's asking after vaccination.
So I did pull up the latest numbers that we have, and so they do change from week to week. But for Pfizer, it's about 1.4, and for Moderna, it's about 2.6. So, I mean, overall, I don't know what that would come to, but those are for overall combined for dose 1 and dose 2. I do have more specifics. But yeah, when you look at observed versus expected, it's the Moderna that actually overall that we get the signal for all when you combine all age groups and strata. So that's the overall incidence. I hope that answers the question.
Okay, great. And one more quick question for Philip here. Are you able to separate out people who are vaccinated with heterologous vaccines? So AstraZeneca plus either Pfizer or Moderna?
Yeah, so the COVID Immunity Task Force was particularly interested in our ability to capture that information. So the short answer is yes. The vast majority, so about 12, I've got the numbers right in front of me, in fact, 12% of our cohort has the AstraZeneca vaccination, but the vast majority of those individuals had a Pfizer and or Moderna follow-up. So we're able to look at that, and we can see a significantly lower seropositivity. Sorry, we can see a lower seropositivity in those individuals who had AstraZeneca first and then followed up by Pfizer and Moderna, and certainly among those individuals who have hematologic malignancies. So yes, that's the answer there.
That's interesting. So not as high as 2 doses of mRNA. Yeah, that's
yes, yeah.
Yeah. Okay, and then there's a question, I don't know who this is directed at, because this is maybe for all of us. Are there any studies in the works to look at vaccine efficacy and complications among children 4 to 11 years? How is this monitored in 12 to 17 age group? What is being planned?
So that's not being done by us, but I am aware of other CITF-funded, PHAC-funded activities that are looking at child cohorts and hospital-based cohorts out of St. Justine Hospital, as well as out of Sick Kids and McMaster as well. So I can't answer that directly, but maybe Natalia can.
I'm so sorry, I was multitasking. Could you repeat the
Oh,
question?
oh yeah, no problem. Yeah.
No, sorry about that.
Yeah, no, are there any studies to look at vaccine efficacy and complications among children 4 to 11? And I'll let you go first, Natalia, and I can jump in with my, and then how is this monitored in the 12 to 17 age group?
Okay, so so the pre-authorization trials are ongoing. So that's the main method right now that we have for looking for on the safety side. But for how is it being monitored in the 12 to 17 was the second question?
Yeah, yeah.
Yeah, so I mean, we do just conduct normal post-market surveillance in this group. And so, you know, recently we've been able to get some information. This might address a different question that was asked earlier for you guys, but we have been able to get some information on the mixed schedules, and so we're trying to look at, you know, if you got 1 dose of Pfizer versus 2 doses of Pfizer, or Pfizer Moderna, or Moderna, or AstraZeneca, and that sort of thing. So we're doing that for every single age group.
Great. Yeah, and from my perspective, I mean, you know, we can do like vaccine effectiveness estimates for other age groups. Like the one I presented today was like 16 and plus, just because, you know, from the initial onset in December, it was approved for use in 16 or older for at least the Pfizer vaccine. But, you know, it went down to 12 in May. And so we can look at vaccine effectiveness in the younger age group as well. We just haven't had a chance to do it yet. And then when it, you know, it gets approved for even younger, we can also look at that. But you know, the thing is, we have to wait for events to happen, you know, kind of the more successful the program is, actually the harder it is to do these vaccine effectiveness estimates, because there's just fewer and fewer events to do these analyses. So I think we're close to the end. There's just a few more questions. There's a question for you, Natalia, on how the safety data are fed up to WHO. Are the results of events fed up to the WHO?
Yes, they are. It's done through the Uppsala Monitoring Center, and so we just basically submit all of our data through that system. And so it's like numbers of cases, basically that we're reporting up.
Okay, great. Okay, last call for questions. I don't know if you'll be able to answer this, Natalia. This is it likely there would be a recommendation for booster vaccine at the federal level in Canada?
So, I mean, the National Advisory Committee on Immunization, although I'm involved with them heavily, I wouldn't want to speak for them, but they're the main body that comes out with national level guidance. Like there won't be like from a chief medical officer perspective, like Dr. Tam wouldn't come out with a recommendation. That's up to the purview of each province and territory's chief medical officer of health. But like in terms of guidance, based on scientific consideration of the risks and benefits, NACI will be coming out with further recommendations in addition to what they've already said for high-risk groups.
Great. Okay, and one last question here from A. Klein. Is there an intent, this is for me, I think, is there intent to look at patients who are immunosuppressed for transplant plus secondary hematologic malignancies? So yeah, that's something that we are planning to do. It is a little bit academic at this point, since these populations have been already recommended to get 3rd doses, kind of like a 3-dose primary series. But we can look at vaccine effectiveness in those, you know, because in the administrative data, we can identify people who have had transplants. So that's something that's in the pipeline as well. Okay, well, thanks everyone for attending today, and I hope this was useful for everyone. I want to thank all of our panelists, and for those behind the scenes, Shaza and Liz and Ida for helping us run this webinar so smoothly. And thank you all for your attention, and take care, and we'll see you at the next webinar. Okay, bye everybody.